Hi, my name is Eric Nussbaum. I'm an athletic trainer at University Orthopedic Associates in Somerset, New Jersey, and I'm honored to speak to you today about rehabilitation considerations for tibial bone stress injuries in adolescents. I'd like to first start off by thanking the New Hampshire Musculoskeletal Institute for inviting me to speak about something that I'm very passionate about. I have no disclosures. Goal of my presentation is to challenge your thinking about the way you manage tibial bone stress injuries, and maybe to cause you to ask the question, why? Why do you do the things that you do with your athletes that have got tibial bone stress injury? We know that it's shin pain is a common problem. There's too many sore shins, particularly at the high school level. They've got prolonged pain, prolonged recovery, recurrent injury, and in the extreme cases, complete fracture. There seems to be a lack of interest from the surgical community because it's not a surgical case. And from the primary care community, these things take so long to really dive into that sometimes we don't have our primary care docs taking as much time as they probably should. And consequently, we end up being oftentimes the primary care providers for many of these athletes with bone stress injuries. But ideally, it takes a team. It takes a lot of people to optimally care for these kids with tibial bone stress injury. So the problem is, one of the problems is, what is shin pain and how do we define it? For way too long, it's been defined or called a shin splint, which I'm going to ask that everybody that listens to my presentation, please try to refrain from using that term because it's got no real value. It's commonplace, it's overused, and it has no medical significance at all to it. And I don't think stress fracture is completely appropriate to call all of them either, because less than 5% of kids with bone stress injury, when they have the X-ray or the MRI, actually show a fracture line on their X-ray or MRI. But with the more common or routine use of MRI, we do know that 85 to 90% of athletes with shin pain do have injury to the bone. So I think it's about time we call these things bone stress injury, because they define, the term bone stress injury defines a gamut. It's kind of a phase of injury from just a little irritation to a complete fracture, and all of them cause shin pain, and pretty much most of them involve injury to the bone. These injuries are classically defined as high risk or low risk injury, with a higher risk injury being on the anterior tibia, the tension side, and they can go on to complete fracture. More commonly, the posterior and medial side of the tibia are considered low risk injuries, but low risk doesn't mean no risk, as we saw from a Louisville basketball player 5 or 10 years ago in the Sweet 16. So they can go on to complete fracture. I added this video just because I think it's important for us as clinicians to remember that we've got a role to play with our athletes. You know, everybody wants to be out competing in these big events, but sometimes they're just not ready. And these things, you know, the downside is a potential fracture. And though some people commend this girl for her courage for crawling across the finish line, I kind of have some questions for the healthcare providers that allowed her to be out and running in this event. So adolescents are not smaller adults. They do have smaller, thinner bone geometry. Their bones are more pliable, less mineralized. And under the age of 17, they've got open physes, which can impact load transmission. Adolescence is a key time for axial growth and hormonal development, and it's also a key time to maximize bone health by increasing bone geometry and bone mineral content. By the age of 20, 95% of lifetime bone health will be laid down, and we accumulate it, or adolescents accumulate 30% of bone mineral density during this phase of their growth process. I think there's some important problems to consider when we're dealing with bone stress injuries, and that includes sports specialization, particularly at an early age, but also specialization during a peak period of growth. And a prime example of that is what's happening with high school cross country, winter track, and spring track. The National Federation is condoning sports specialization by allowing high school students to run 10, 11 months a year, be involved in competition that's doing one activity, and they're all going straight forward in their running events. And I don't think that sports specialization is a problem. Also, sports in our culture. Sports is an important part of our American culture. It's an important part of the adolescent identity. And we've got this mentality, no pain, no gain. And I think that sometimes our culture can impact the way kids react to some injuries. A couple of years ago, I had my track team made a t-shirt, and on the back of it, it said, "Pain is weakness leaving the body." I think I failed as an athletic trainer and trying to educate some of my track athletes. We know that 50% of injuries seen in a pediatric sports medicine clinic are related to overuse. Stress fracture incidence is greatest under the age of 20, and that age period between 14 and 16 years of age is really an increased period for heightened bone stress injuries. One factor that I think is overlooked within the adolescent population is the impact of psychosocial stress. And impact of increased stress causes increased cortisol. And we know that increased cortisol and increased stress can have negative impact on just general health, on the cardiovascular system, can negatively impact sleep, concentration, eating habits, drug and alcohol use. It can have a lot of negative impacts. So I think it's important to really address or to consider the psychosocial stresses that adolescents may be undergoing while we're engaging them in our rehab and our recovery period. It's also a period of social acceptance where, being a part of the team is a big thing. So they're going to feel a lot of pressure from coaches, from parents, from peers to be a part of a team or to be active and to be out on the field and competing with the rest of the team members. And it's also a period where body image is very important. That can have other impacts as well. I also want to make a quick note that bones are living dynamic structures, and not all bones are alike. That just because you're an athlete doesn't mean that you've got healthy bones, and that different athletes have different adaptations depending on the sports that they play or that they get involved with. And I use two examples here. Volleyball players generally have greater periosteal circumference from all the axial loading and jumping that they're doing, but they may have a decreased bone mineral density. Whereas soccer players have got greater cortical width because of the change of direction that they're involved with their sport. Playing ball sports is thought to be protective for suffering a bone stress injury. And I think that is due to the fact that there's repetitive changes in direction, and they involve jumping and decelerating, which all help to build the strength and robustness of the bone. A knowledge of bone repair is important. And I think that we need to understand what osteoclasts and osteoblasts do, and that bone repair and bone recovery occurs over a period of time. It doesn't just happen in a short snippet of time. That the bone grows in size before it grows in density or gets hard, and mineralization of the bone can take a long time. So I think some of those facts are important to convey to some of our student athletes. We also know that the bone responds to stress. We all know Wolff's Law, and that bones or tissues adapt to the stresses that are placed on them. Too many stresses and they break down, not enough stress and they can grow, but they may not adapt in an optimal way. Also consider the mechanostat theory, where Frost kind of redefined Wolff's Law, and that the change of structure, they change in mass and architecture, or the width of the bone to stress. And then also mechanotransduction, where it actually stimulates biochemical signals, which may be important for changing the quality of bone. I want to draw your attention to an important paper that was published this year in American Journal of Sports Med. by Dr. Pop and Dr. Ackerman and the people at Mass General, where they looked at changes in bone mineral density over 12 months after a tibial stress injury diagnosis. And they found that bone density declined in both the injured and uninjured legs, and it didn't return to baseline for 3 to 6 months after the diagnosis. And I think this is important because we know that adolescence is a prime time for developing lifetime bone health. We know that bone injury, there's a residual period of weakening, and that it can be a weakening not just of the injured bone, but also of the associated or the contralateral bone, that it begs the question, what impact does prolonged or recurrent injury have on lifetime bone health and of the occurrence of osteoporosis and future fracture risk? So if a high school athlete who's in the prime of their bone building years goes from freshman year to senior year and they always have shin pain, what impact does that have on their lifetime bone health? I think that's a good question and something that hasn't been thoroughly proven yet, but there's been some smoke. So I think that there is something to consider there. And I apologize for kind of dating myself a little bit. This is a picture of Olga Korbut, who won the Olympics and won the gymnastics Olympics in 1972. And the reason I put her up here is I heard Olga Korbut speak several years ago. She was repping an osteoporosis drug. And while she was doing her presentation, she talked that at the age of 25 or 30, she had a DEXA scan of an 85-year-old woman. And it really caused me to think about, the long-term impact of these kids with chronic injury, these kids that are exercising, competing multiple hours, that 20-hour-a-week kid, that multiple team kid, that all year round athlete, that sports specialized athlete. What's the impact on lifetime bone health? And I think that we as clinicians have to consider that as we talk and we work with our athletes as they're recovering from bone stress injuries. So how do you best manage a tibial bone stress injury? It's kind of the million-dollar question. I asked a lot of athletic trainers as I was preparing for this talk. There's no clear-cut way. There is a lot of ambiguity, and it's obvious that people are overwhelmed by the commonality of this injury that we see in our high school population, our adolescent population. So I think it's important that we as clinicians help to push our kids to identify the problem. And that's, pursuing imaging, X-ray, additional imaging, if the radiology is normal, pursuing onto an MRI, really pinpointing down, what is the extent of our injury. And then once we've identified and classified what the injury is, it's important to address the intrinsic and extrinsic factors that may have contributed to causing that injury. And I think here's a real key point where we can make a difference in a kid's life. There's over 60 of them, 60 different factors that have been noted in the literature as being associated with bone stress injury. And from a primary care perspective, becomes overwhelming to try to address all of these things. But I think that we need to hit the major ones. And I think things like low BMI, eating disorder, RED-S, menstrual disorder, prior bone injury, a family history of fracture or bone injury, sleep histories, and changes in training are some of the more common ones. But I think it's important that we address these factors as well. And, pushing for an MRI helps us to kind of clarify the extent of injury. There's a paper written by Miller, published in Sports Health in 2018, which looked at collegiate athletes, 57 stress fractures in collegiate athletes, a little older than our population, but also including, some of our older adolescents, that all bone stress injuries took on average 12.9 weeks to return to sports. The tibia was 13.3 weeks. So depending on the grade, there's a longer recovery period. So, the mean is 13 weeks. It may be 20 weeks with somebody with a true stress fracture or a grade 4 bone stress injury. So I think it's important that we discuss this with our athletes, particularly early on as they're going through the rehabilitation phase, so that we reinforce the importance of allowing the bone to heal and to properly recover as we're going through the recovery process. I'm involved with the bone stress injury rig through PRISM, and we were working on a paper with I've been working on a paper with Yukiko Matizaki, excuse me, and Eric. Yukiko's at HSS, and Eric is at New York Institute of Technology. Both of them are physical therapists, and we did a lit review trying to identify articles that specifically noted rehabilitation programs for adolescent athletes with tibial bone stress injury. And in doing our search, we identified 55 articles that noted that rehabilitation was important to do in the recovery process. Most of those were military or collegiate studies, or involved specifically runners. We did identify 9 that detailed a phased approach and kind of detailed the rehab process a little bit more. Very few randomized controlled trials. Only 1 was a level 1 study. They all suffered from low numbers, and they didn't have strength of recommendation taxonomy. But the glaring point we found was that none were specific to adolescents. And I think that's a real problem, something that we need to work on. Just kind of a review of the 9 studies that we had, only 3 of them actually worked with patients, and the most patients that were involved in the 1 study was 74 with a low of 12. So numbers was an issue. And then the other 6 were narrative reviews, with 1 systematic review by Bolthouse, which was a pretty good paper. I encourage people to look at if they're looking for information. So if we break down these phases of recovery, we have relative rest, rehab, graduated return to running, and return to sports, is pretty much noted in these 9 different phase programs. Relative rest is important to decrease pain and inflammation. It's important to cease the activity that perpetuated the injury, and the relative rest was listed as 1 to 4 weeks. But there was no definition or clarification on why 1 for some, 4 for others. They used subjective pain as the only rational guideline for that. But in the literature, this relative rest period may last as long as 14 months. And I believe I saw 1 military study that said up to 24 months, may be possible. So it is something that's not well defined in terms of, the duration that we need to rest in this relative rest period. They all noted that modalities for pain should be used to help to reduce the pain, and that non-loaded aerobic training is all right and encouraged to do. Pool running, swimming, bike, Ultra G, elliptical, non-loaded aerobic activity. But there was no mention of intensity, duration, or monitoring of the stress that was going on, with those non-loaded activities, or what the impact of any of these duration of rest or aerobic training was on the healing bone. So I think that's problematic. And again, criteria for progression, subjective pain versus objective criteria. I think it's a real issue for adolescents, particularly for those that may be their first experience with injury. They don't know how to interpret pain. They pretty much all have a desire to return to sports. They may be suffering pressure from their coach, from their parents. I've seen that be a big issue, or from their peers to get back to the field. What's taking you so long? And it's also important to consider that a 2 on the pain scale for some may be an 8 for others. And that with most athletes, when you win, nothing really hurts. So as their teams are doing well, they want to be out there, with them as well. So I think using pain as the criteria for progression is problematic in the adolescent population. I want to suggest that we use objective criteria, and some criteria I'm going to recommend is a vertical single leg hop test, which we we kind of wrote up a little bit in Sports Health in 2021. You want to look at their ability to do a vertical single leg hop from their toes versus flat footed. You want to note the height from one side to the other. Note their landing time, how much knee bend that they have when they're coming down and making touch with the ground, and also are they drifting or deviating from being able to hop on a specific point. Single leg heel rise test may be a good test to use for determining whether or not they're ready to return to running. It's a test that was publicized by Yoakum, where they found that using a metronome set to 30, that 25 was normal. Other things, a time side plank, a step up test. What about the use of a repeat x-ray at 6 weeks when you may start seeing some periosteal new bone formation or endosteal new bone formation? Or what about the use of musculoskeletal ultrasound and the notation of periosteal edema or an increase in periosteal edema, which is one of the first steps to adding periosteal bone or the outer shell new bone to make to improve bone geometry. Maybe something to consider. And then I also throw in the thumb test. That kid that says, yeah, I'm ready to go, I don't have any pain today. Okay, sit on my table. Let's see how sore are you, just to to a firm pressure or to check them. So all those, I think it's important to use objective criteria versus subjective criteria when we talk about the youth population. So looking for hop, being able to hop off the toes, and do they get increased pain? You'll note that this patient's got some drifting. They can't hop in a single area. They're kind of all over the place, and they get increased pain. Can't fool the hop test. So you have decreased height, increased landing, and increased pain. Look for the flat foot hop. The foot slap is kind of easy to recognize. Decreased height and drifting. Increased time in between their ability to jump. They're apprehensive in wanting to do that jump. Now, this young lady told me she was completely fine. She had no pain. There's no reason she couldn't return to running today. I tend to think that she's still having some pain and disability. So the heel rise test to a metronome. I actually use a little scale on the countertop. They can use some finger pressure for balance. I don't want the finger pressure to exceed 1.5 pounds or 2 pounds. Heel rise should be at least, they stop when they get to like 50% of what their original heel rise height is. You do it to an online metronome set at 30, so it's 1 heel rise every 2 seconds. It's a good way to determine whether or not an athlete is, maybe ready to start their running program. So phase 2, we talk about some of the components that we want to add in our rehabilitation program. They surveyed orthopedic surgeons. 48% recommended stretching of the gastroc as being important. I think pretty much most athletic trainers and physical therapists will say stretching is important. And they'll also say that strengthening is important. I think that there are 2 etiological components that we know that are probably involved somehow. One is the soleus is involved, and also that bone remodeling is insufficient to compensate for persistent insult to the tibia. So we know that the bone has been overloaded and it can't compensate for that continual stress. So we know these 2 things. They're not necessarily facts, but I think that they're strong inferences that they're kind of at the root of some of the shin pain problem. So in our rehab process, we want to kind of address those subjects. So stretching, not sure how much stretching is really of value. Adolescents are inherently tight. And do you do static or ballistic stretching? There's kind of some within the stretching literature. There's been a lot of things published in the stretching literature. but a lot of that has been called into question in terms of its value, both short-term and longer term. I think there's more value of repetitive stretching over a longer period of time than there is in short bouts of static stretching. There's also some people that call into question the value of gastroc stretching early on in the recovery process because they feel that it negatively impacts the healing bone. So just some things to think about with recommending stretching. Strengthening, the questions are, what do you strengthen? You know, what are you looking to strengthen? Your low leg muscles, the hips, the core, the foot intrinsics. Where do you start? How many times a week do you do it? Do you do it based on recovery, or do you do it based off of how good their insurance is and how many times they can come in for therapy? Do you do it loaded or unloaded? Do we do more strength work or more endurance work? What's the optimal sets and reps? How about load management? Load management is a big catch term in athletics nowadays. I want to kind of steer you towards Brown's article and also some of the writings by Rich Willey and his group, as they address some of these questions pretty good in their literature. But these are all things to think about. And what's the impact of our rehab on the bone? Can we make the bone stronger through our rehabilitation? Now, we know, I threw this one paper in here just to highlight the fact that that gastroc tightness should not be interpreted as pathologic finding. It is a common finding, and that dorsiflexion decreases with increasing age in children. So as you get older, particularly in that adolescent age group, they're going to have tight gastrocs. And they also found in the study that it was not associated with injuries or problems. So strengthening. We know that by loading the bone, that it increases size in athletes. So by doing heavy weight training, we can increase the size of bone in athletes. But we also know that the bone can become deaf to loads after a small number of reps. So the value to bone to increase bone size is really in a very limited window of number of reps. It's maybe in the 15 to 30 rep range than it is in the 100, you know, or 60 or 80 range in terms of reps. So you want to make your reps matter. Forces that involve axial loads, like such as marching, single leg squats, or loaded carries, can all impact or stress the bone. Heavy loads applied quickly has been purported, particularly in the form of plyometric jumps, may be exercises that can help to actually build bone size and bone geometry. Now, again, it's a progressional thing. Something like plyometrics should probably start out when they can squat 1.5 times their body weight and start in the pool. But the load rate is important when we talk about bone building. So to realistically load the soleus, you probably need to use a machine because you just can't do it with bands, and you can't really do it on just toe raises. But, you know, so there's different things to really consider. Don't overlook the value of rest, particularly during that 3rd week period of the recovery phase. There was a military study that was referenced that they decreased their incidence of stress fractures by decreasing their activity in the 3rd week of training. So literature suggests that specific exercises or training can improve bone mass and strength. And keep in mind that muscular contraction forces are also a source of mechanical stimulation. So any activity that you're doing with the lower leg can stimulate or impact the bone. It's important to consider the intensity and the number of reps that we're using with our strengthening process. I think it's also important to keep in mind the youth position statement on resistance training because there are differences between adults and youth, but there can be benefits gained by the youth population with graduated weight training. And then a graduated return to running. Where do you start? Do you start with walking? Do you start with running? How far? Do you go 1/4 mile? Do you start with 1/2 mile? What are the sport specific requirements? Do you start on land or do you start with a treadmill? If you start on a treadmill, do you start with an incline rate versus a flat rate? And what's the stress of the soleus? that can occur with the differences. What about gait analysis? When do we start our gait analysis? At what point in the rehab process is a gait analysis necessary? How much do you progress? Do you progress utilizing the 10% rule, which is one of the rules that's really purported by a number of people in the literature? But is that appropriate for all individuals? I encourage you to check out a video we have on our website at UOA. Was a presentation done by my old boss at Rutgers, Don Kessler, who's now with the Navy SEALs in Coronado. He came up with a program for reducing their stress fracture incidents, and he's called it Running Faster, FASTER. I encourage you to take a look at that. But where's the evidence? Where's the evidence for us in our decision-making on our graduated return to running? Now, if you look at evidence-based prevention or interventions that may be used, I just pulled this one paper because I thought it was pretty good. There are a number of them that look at various variables that may be utilized to treat individuals after bone stress injuries. They found that the supporting studies graded out very low quality. They had design flaws, they lacked control groups, and they lacked adequate numbers. So even the recommendations had a low score in terms of value for those recommendations. There's no statistically significant results noted for any of the prevention methods, and they were all pretty much of low numbers. So in summary, we want to remember that the adolescent athlete is distinctive and unique. Consider basing your progression on objective criteria versus subjective. Base your recommendations on the evidence and do your rehabilitation and treatment to improve bone, not just to improve the pain that's associated with a recovering tibia. Don't overlook the potential impact on bone health, lifetime bone health. And I appreciate your patience and your attention. Thank you very much.